Hello, and thank you for joining us for today's NILE webinar. This is Brianne Van Dyne, the Education Manager for Immunize Nevada, and I will be today's moderator. Before we get started, I'd like to review a few housekeeping items. First, if we should become disconnected for any reason, please call right back and we will continue. Second, please locate the chat box in the bottom left-hand corner of your screen. If you have any questions, type them in the chat box and we will address those questions throughout and at the end of the presentation. Or actually not throughout, at the end. We'll save all questions for the end. I apologize for that. Lastly, if you've requested nursing or pharmacy continuing education credits for today's webinar, please make sure you complete the survey in the post-webinar email. The email will be sent out by the end of today, and all CEUs will be emailed out within the next week. Before we begin, I'd like to provide a little disclaimer. Immunize Nevada's NILE webinars are made possible by the generosity of speakers who donate their time and expertise to benefit the coalition. The expectation and goal is for community partners to gain knowledge on immunization-related topics through a non-branded, unbiased presentation. I'd like to now turn it over to our speaker, Dr. Wilbur Chen, who is an Associate Professor of Medicine with the University of Maryland School of Medicine, where he also serves as the Chief of the Adult Clinical Studies Section at the Center for Vaccine Development and Global Health and Director of the University of Maryland Travel Medicine Practice. He is a board-certified infectious disease physician with a focus on infectious diseases of travelers and translational vaccine research. Welcome, Dr. Chen.
Thanks so much for having me. I hope that everyone can hear me. I'm going to try to be ambitious and get through 6 different vaccines today that are relevant to travel. So you should be looking at slides right now. It says vaccines to mitigate risk during travel. And so I do just want to make sure that I disclose that I received research grants from PaxVax and was the PI for the licensure studies of Vaxchora, which is our cholera vaccine that we have licensed in the U.S. I won't be saying anything off-label, and I'll be basically quoting information from the ACIP recommendation. So I believe that this should be balanced, but just wanted to make sure that I disclosed that. Now, I will try to cover 6 common travel vaccines within this hour. I hope that I am able to do that successfully. And hopefully we are able to achieve all of these objectives. Now you can see that I'll be unable to address certain parts of a travel clinic visit, which is talking about other travel vaccines, maybe talking about travel insurance, which is perhaps an important part of a travel practice, and talking about malaria, mosquito prevention, altitude sickness, those sorts of things as well. We won't cover today. So what you're seeing here is a nice picture. This is from my travel a couple of years ago to Ethiopia for a research, but I was basically in the highland areas of Tigray, and it's very hot, and we seek refuge. You can see our Jeep is seeking refuge under a tree there, and that's kind of the image of what I hope that we achieve with vaccinations, is that we achieve some level of protection or complete protection with the vaccines that we're administering from the harsh elements that we get exposed to during travel. All right, so these are just a few more fun pictures of when I was traveling through in Ethiopia during that visit. And basically to highlight that there is, you engage in high-risk activity, no matter how adventurous it is that you are, and that means that you'll be at high risk for certain types of infections, and we'll try to cover those in the next hour. So there are a number of licensed vaccines that are available here in the U.S. We're only going to cover 6 of them, but this is just to kind of give you an idea. The cross-out areas are ones that are not licensed for, here in the U.S. Either they might be for specialized populations like the military, for anthrax, smallpox, and tularemia, or for, say, tick-borne encephalitis, which is really for Eastern Europe. So I'll organize this lecture in this manner where I'll talk about the pathogen, the epidemiology, clinical presentation, risk assessment, and then the vaccines available, and we'll talk about those vaccines. So the first topic is to beware of mosquito bites. This is a picture of my elbow, and I left the window open one night and woke up, and of course I had to suffer from that error and had some mosquito bites. So in certain areas of the world, you will want to worry about yellow fever virus infections. It's a flavivirus. I'll just mention that there are a lot of other flaviviruses that are out there, such as dengue, such as Zika. West Nile is another flavivirus, and Japanese encephalitis virus, which we're also going to talk about today, is another flavivirus. They're all common because they're transmitted by the bite of a mosquito, the Aedes aegypti mosquito. Yellow fever causes a significant amount of clinical disease, but it's really in two areas of the world. And there's substantial underreporting because these are diseases of less developed countries, and perhaps there's incomplete reporting, either because it could affect the economies of those local areas, because maybe it affects tourism, or because it's simply just not assessed very well. The surveillance might not be as complete as it might be in a developed country. So I mentioned that it's in really two areas of the world. So you will want to think about yellow fever in the Amazon basin of South America, where you can see highlighted in red there in South America, and also sub-Saharan Africa. In sub-Saharan Africa, we have a higher case fatality rate with yellow fever than we do in tropical South America. But it's still important for us to just recognize that there are even ongoing outbreaks of yellow fever even right now. There is some seasonality to these infections, and you'll remember that it's because it's tied in with mosquitoes. You'll think about that the peak is with the peak of mosquito breeding. So it's usually at the wettest times of the year for these locations. So in South America, it's usually January through May, where there's peak rainfall. And in West Africa and Central Africa, it's usually around July to October. But again, these in the hottest areas of the world, where it's tropical pretty much all season around, even when it's not the peak, there is still transmission of yellow fever. So the clinical presentation you might want to be familiar with, just so that you can describe it to your patients, is that you can have the mosquito bite and have the incubation from about 3 to 6 days. Then you'll have the onset of non-specific flu-like symptoms. That's kind of the initial stage. And you might have a brief remission after that initial non-specific illness. And then you could enter into what's called the toxic phase. Not all people, 15% of patients will have this, but this is where you'll have much more severe disease, where you'll have high fevers, nausea, vomiting, the myalgias and the arthralgias, but then you also have end organ disease, which could be jaundice, renal insufficiency, cardiac instability, multi-organ failure, basically, bleeding, diatheses, and basically this is the part that is tied with high case fatality ratios of 20 to 50%, and this is because there can be hepatorenal dysfunction, basically end organ failure. So this is what we're trying to prevent for our travelers. In West Africa, we think that if there's a 2-week stay for a very adventurous traveler who's not vaccinated going into these yellow fever endemic areas and getting lots of mosquito bites, it could be on the order of 50 illnesses per 100,000 travelers. In South America, it might be 5 illnesses per 100,000. But again, it could be that traveler that you're sending. So you do want to talk to your more adventurous travelers who will be prone to getting more mosquito bites. If it's a traveler that's staying at a 5-star resort and only being there for a weekend, then much more limited risk. But it's going to be much higher risk for those people who are going to be camping, hiking, staying in the outdoors for long periods of time. So this 2-week stay is just to give you an estimate in your minds about the risk. Now, the prevention is really trying to prevent the mosquito bite in the first place, which is why clothing and insect repellent is important. But then you also want to mention vaccination. And there is no specific treatment other than supportive care once you get that illness. So there are a number of globally available yellow fever vaccines, but here in the U.S., we only have the one, which happens to be made by a company named Sanofi Pasteur. It's a single-dose vaccination, approved for children as young as 9 months of age and older. And if you're a clinic that is able to administer it, then you basically are able to validate or stamp and validate an international certificate of vaccination. Now, since June of 2016, by international health regulations, only a single dose of yellow fever vaccination is required. So there's no more requirement for boosters every 10 years. So you can just remind your patients about that fact, that if they received it back in the 1990s or even in the 70s, that if they still have that certificate, that stamp vaccination book, then it is valid. All right, well, maybe some of you know that practice travel medicine, but right now Sanofi Pasteur is updating their manufacture facility, so it's been offline, and basically since about 2017, yellow fever vaccine, new yellow fever vaccines have not been manufactured by Sanofi Pasteur here in the U.S. So we expect that yellow fever vaccine will become available sometime at the end of 2019. They had initially thought that they would be available in 2018, but now we're about a year back. And we're hoping that this will be available. So what's happening right now is that some yellow fever clinics are importing the European version called Stamaril, also made by Sanofi Pasteur by the same manufacture process, but it happens to be that facility is not FDA approved, so therefore it's not officially US FDA licensed. And so those are the clinics that are available to administer vaccinations. So in 2019, hopefully the rest of travel clinics in the US will have yellow fever vaccine available. So the contraindications to this vaccine, it's a live attenuated vaccine. There are some contraindications to, of course, the components of the vaccine itself. So if people have had hypersensitivities or anaphylaxis to those components. If a person is immune deficient, whatever the reason, because it's a live attenuated virus vaccine, then that's a contraindication. And it's contraindicated for very young children, infants less than 6 months of age. There are precautions. So in other words, for infants aged 6 months to 8 months can get the vaccine. It's FDA approved for 9 months and older, but that doesn't mean that you can't give it for infants 6 months and older. It's also a precaution to give it to older adults, and that's because I'll show you in the next slide about the potential adverse effects with aging. Pregnant women also is a precaution. I really prefer not to administer this live attenuated vaccine to pregnant women. And it's also a precaution to HIV patients that have CD4 counts between 200 and 499. So above 500 should be fine. And for HIV patients with a CD4 count of less than 200, it's contraindicated. So in other words, for those patients with these precautions, that means that you would want to document your conversation about potential safety and adverse effects with this vaccination. So what am I talking about? Well, there are 10 to 30% of people that have mild systemic reactions. That's not really my worry. There are 1.8 cases per 100,000 vaccinations for hypersensitivity reactions, but really what we're concerned about is the vaccine-associated either neurologic or viscerotropic disease, which basically is systemic dissemination of that live attenuated virus. So it resembles a milder, hopefully milder form of yellow fever, but still, again, it can go to the brain and cause meningoencephalitis, Guillain-Barré, or maybe a bulbar or a Bell's palsy, or it could cause multi-organ involvement in the immune compromised and is associated with case fatalities. So again, This is something to be aware of because it is a live attenuated virus vaccine. And so for older adults, there is a higher predilection for this rare adverse effect. So it is rare, so you want to put it into that context, but for older adults, it is more common. It's still rare, but it's something that you would want to document in a conversation with these patients. But this vaccine is highly protective. In endemic populations, which means that these people are living there, their lives, and being exposed to mosquito bites that have yellow fever, people who are vaccinated have a high level of protection. Among vaccinated travelers, there's only been one case, and it was a non-fatal case of a person who was vaccinated, or at least documented to have been vaccinated, and came down with yellow fever. Among the many millions of people that we send to yellow fever endemic areas and travel and receive yellow fever vaccine. There are ongoing outbreaks of yellow fever, so in Brazil and Nigeria, Central African Republic as well is having and Congo. So there are some hotspots where yellow fever still is breaking out in those endemic areas. So we want to also be aware of foodborne risks. So what am I talking about here? Well, I'm talking about enteric fevers, which includes typhoid. Enteric fevers is really a name that also includes paratyphoid fevers. The scientific name for typhi and paratyphi is Salmonella enterica subspecies enterica, serovar typhi, or serovar paratyphi, and there is paratyphi A, B, or C. Now, here in the U.S., you hear about salmonella infections as well, and those are non-typhoidal salmonellas. So that's not what we're going to be able to protect against with this vaccine. This vaccine actually only protects against Salmonella serovar typhi and not the paratyphis as well. But it is something that's transmitted by fecal-oral transmission, so it's something that you ingest. The epidemiology is that it's associated with being in areas with poor sanitation or lack of access to clean water. So it basically has a very wide world distribution. The highest risk is usually associated with Southern Asia. There's really no seasonality to it. Again, what you're thinking of is a pathogen that is excreted from feces. It's not mosquito-borne, so it's basically all year round. Now, the incubation from exposure and ingestion of these pathogens of Salmonella serovar typhi is an incubation of about a week to up to a month. It's an insidious onset of gradual fevers and fatigue and belly aching and those sorts of things, and it can go on for many weeks. And usually you'll have, stepwise increasing fevers, then you'll have some increasing abdominal pain in that second week, and then the third week you'll have hepatosplenomegaly and this predilection to intestinal perforation and bleeding. That's about 15% of people that will have this very serious complication, which could lead to septic shock, peritonitis, because of the perforation and those sorts of things. And even among people who recover and don't have that serious complication, there are some people that would go on to that chronic carrier state. And they will continue to excrete these organisms for a long period of time, over a year. So it is, the chronic carrier state is associated with people who have gallbladder disease. Now, the risk to travelers is, again, if you look at the data, the CDC has looked at it. It's usually associated with people with prolonged stays and locations where basically they're going to less developed settings and where there's less access to either good sanitation or clean water. Prevention is really observing the safest of food and beverages and to be vaccinated. Treatment is rehydration and prompt antibiotics, and so there's a lot of typhoid that is antibiotic resistant. So you do want to recommend that they get blood cultures performed at a local medical clinic so that they can figure out if they have a quinolone or some other antibiotic resistant organism so that they can receive the best antibiotics. Now, surgery may have to be performed if it goes on for those few weeks where there might be that risk of ileal perforation. So again, that might be necessary. And then steroids are necessary to reduce the amount of inflammation associated with the bowel perforation. There are a number of typhoid vaccines that are available globally, but there are only 2 here in the U.S. There's something called Typhim VI made by Sanofi Pasteur, and Vivotif, which is made by Paxvax now, which was just bought by Emergent Biosolutions, EBSI. So one is an injectable vaccine, the other one is an oral live attenuated vaccine. The injectable vaccine is a single dose intramuscular injection approved for children 2 years of age and older. And the oral vaccine is a series of 4 capsules, as you can see in the picture there. And you take those capsules every other day on an empty stomach. And that's approved for children 6 years of age and older. Of course, many children 6 years of age, even up to 10 or 12 years, have difficulty swallowing pills, but it is approved for this age. So you will want to kind of see what the preference is for that patient according to their preference for getting injections and avoiding needles perhaps, and their ability to swallow pills. Now there is an advantage or a disadvantage, depending on your point of view, about the duration of protection. So the injectable vaccine basically lasts for about 2 years before you have to get a booster, and for the oral vaccine it's about 5 years. Now 2 to 3 years or 5 to 6 years is because if you live in Canada perhaps or in Europe, the package insert says that you boost after 6 years. So it's kind of odd, you know, we have a slightly different package than the Canadians or the Europeans for some of these vaccines, but that's just a nuance that you don't necessarily have to be familiar with. Now there are some contraindications and precautions. So the injectable Typhim VI vaccine really is just injection site reactions and hypersensitivities to the components in the vaccine itself or prior anaphylaxis. With the oral vaccine, because it's a live attenuated, you do want to be aware that immune deficient patients cannot receive that vaccine, and that because it's a live bacterial vaccine, that you cannot use it concurrently with antibiotics. So let's say, for example, you have an adolescent that's taking an antibiotic, doxycycline, for their acne. They won't be able to receive the oral vaccine because they'll kill the vaccine basically before it has efficacy because they're on the antibiotic and will kill the vaccine before it has effect. So there are safety and adverse effects. So with the injectable vaccine, of course, there's injection site reactions, some headaches, fatigue, fever. Again, it's on the order of what I usually see with, like, say, a flu vaccine or a tetanus vaccine. Nothing more reactogenic than that. It's well tolerated otherwise. And the oral vaccine is actually well tolerated as well. So that abdominal pain, nausea, diarrhea, vomiting, is very mild. Usually people take it and they're not interrupted with the rest of their day, and it's usually on the order of what you would expect, or I would expect, for a person taking an aspirin or an ibuprofen on an empty stomach, those sorts of reactions. It's very mild and well tolerated otherwise. So what is the level of protection? Well, there have been a number of studies that have been performed, but basically you can boil it down to what's in that blue box, which is about 80% efficacy with either vaccine. So really, these two vaccines are equally efficacious, and basically one is not technically better than the other, although there are certain features that some people may find advantageous, such as, you know, some people may want to avoid a needle and like the oral, and some people like the longer duration of effect, 5 years versus 2 years with one versus the other. But otherwise they are equal, and again, the oral vaccine is contraindicated for the immune compromised. Okay, so I just want to remind you that enteric fever, I should say typhoid fever is indistinguishable clinically from enteric fevers, which means that whether a person has typhoid or paratyphoid fever, clinically it's indistinguishable. It's only upon performing those blood cultures that we are able to distinguish what the pathogen is. So just be aware that, again, our vaccine only protects against typhoid and not against paratyphoid or other salmonella, the non-typhoidal salmonellas. There are other risks with ingestion of food or water that could be contaminated. I hope you're having fun looking at these slide pictures of me enjoying my trip in Ethiopia. So hepatitis A is another pathogen that is common in contaminated food and water. It's also transmitted fecal-orally. It's caused by a virus. This virus is also distributed worldwide and is associated with poor sanitation, hygiene, and lack of access to clean water. Now, here in the U.S., you might be aware that even in Central and South California, there is an ongoing outbreak of hepatitis A among the homeless, IV drug users, and men who have sex with men. So that's been reported recently by the CDC. Well, recently meaning within the past year or two, we've actually known about this ongoing outbreak. So hepatitis A vaccination is an important part of travel, but important for us here in the U.S. as well. Upon exposure, the incubation period can be up to a month or even up to 50 days. Now, for younger children, they have usually asymptomatic disease. For older children and adults, there is more of a predilection to have very profound clinical disease, which is jaundice and abdominal pain. The clinical illness basically is a jaundicing febrile disease, but you can also have the dark urine, clay-colored stools associated with it as well, which is indicative of the hepatic dysfunction that is associated with the viral infection. Now, the duration of illness can be 2 months. It's very prolonged. There is a case fatality. It's relatively rare, but it does happen, and case fatality is higher among older adults, 50 years of age and older. But the illness, certainly is prolonged, so you do want to warn travelers about it, even if it may not kill them, but it still causes prolonged illness. And there are risks that have been documented among U.S. travelers, Swedish travelers, Dutch travelers as well. So there are a number of globally available hepatitis A vaccines, and in the U.S. we have 3 different ones that are available. There's Havrix and Vacta, made by GSK and Merck, respectively. They're basically, the same to me. They're both 2-dose vaccinations. The 2-dose schedule is that they are given 6 months apart at minimum, and those 2 doses may be separated even a year apart or longer. The package insert for each of those have a different range, but I'll talk about the upper end of the spacing of those 2 doses in just another slide. Now, there's also something called Twinrix, which I just want to bring to your attention is not approved for children. It basically has a slightly lower dose of the hepatitis A portion. So it's a 3-dose vaccination because basically what you're doing is combining hepatitis A and B together. So think of it as being administered just like your hepatitis B vaccine, but you are able to achieve hepatitis A protection through this vaccine if you deliver all 3 doses. So you cannot, say, for example, give a dose of Havrix and then a dose of Twinrix and think that you call it a day for hepatitis A. Okay, you need to stick with Twinrix if you're going to start with Twinrix. Hepatitis A vaccination has been routine vaccination for children since 2006. So it's mostly for adolescents and adults that you'll be, unless you have vaccine hesitant children that are coming into your clinic that are now seeking hepatitis A vaccination. But it's routine vaccination since 2006. Okay, so contraindications, prior anaphylaxis or hypersensitivity to the vaccine components. There is some latex in the vial stopper, but it is a killed vaccine, so you're not worried about the immune compromised. The immune compromised can and should be vaccinated against hepatitis A. Even your liver transplant patients should be vaccinated against hepatitis A, preferably prior to transplantation, but again, this is to achieve protection against further insults to the liver. Now, safety and adverse effects, again, this is a pretty well-tolerated vaccine. What you're seeing is injection site reactions and maybe some systemic reactions that are really on the order of what I would expect for a tetanus or a flu shot as well. So it's pretty well tolerated. Nothing other than the out of the abnormal, I would say. Now, the level of protection that you achieve, for example, if you have, and I do in my clinic, have travelers that come in only 1 week or even 4 months before travel, but still are not able to get the full 2 doses. Remember, I said 6 months apart of those 2 doses of hepatitis A. So what happens if you only give them the 1 dose before they travel? This is a common question that comes up. Well, with that first dose of vaccination, we typically will see about, and with this study here that I'm documenting, 94% protection among adults and 97% protection with the single dose vaccination. Now the protection achieved with the single dose does drop off after about a year. So it's important for you to achieve that second dose. But what happens after the second dose that's administered for hepatitis A is that you have lifelong protection and you achieve 100% protection among your patients. So that's an encouragement for them to complete that second dose upon returning back from their travel if you're only able to achieve that single dose before they travel. Okay. Now, what happens if they receive that 1 dose before travel, then they completely forget about completing that second dose, and they're coming back to you 5 years later, and oops, they never achieved that second dose. You're reviewing their vaccination record. Well, it's okay. Give them that second dose 5 years later, and it counts. What I'm showing you are some smaller studies that document basically that there's really no upper end. So if you have a person who's coming back even theoretically 10 years or 20 years from that first dose, that second dose counts. So a delayed second dose is no problem. It's just that you don't want to give those 2 doses closer than 6 months, but anything after 6 months is fine, as long as you can document that first dose. Now, well, on the other hand, what if you can't find documentation of that second dose, and maybe in reality they did, and later on they find it? What happens? Well, that third or even a 4th dose of hepatitis A vaccination is not going to hurt them. It's just basically a vaccine that you could have avoided, or they could have avoided paying for, and so I try to avoid excessive vaccination, because they have to pay typically out of pocket, but it doesn't hurt them. It just is something that, again, if we could have avoided it, we could have saved them a little bit of money. Now, this is a question that I usually ask, and so I'm not going to have you do an audience response, but basically there are a lot of flaviviruses out there. Chikungunya is not a flavivirus, but it is mosquito-borne. So it's just to remind you that there are a lot of other mosquito-borne infections that are out there. But Japanese encephalitis virus is a flavivirus transmitted by mosquitoes, and so you just want to be aware of it. It's in only certain parts of the world. It also is probably substantially underreported. Again, just like the reasons I outlined for yellow fever as well. Now, the geography is limited to South Asia and East Asia. And it's also limited to rural agricultural areas, which really in your mind is those areas that are much more remote and probably engaged in a lot of, rice farming, where there's a lot of standing water in those rice paddy fields. But Japanese encephalitis infection is associated with a high case fatality ratio and is associated with a high level of encephalitis, basically of that brain infection that we're trying to avoid. There is seasonality because, again, it's associated with mosquitoes and the bites of those mosquitoes. The clinical presentation is such that not everyone has profound clinical symptomatology. We really think probably less than 1% of people who are exposed to the Japanese encephalitis virus actually develop apparent clinical symptomatology. That contributes to the substantial underreporting of this infection. Only 1 in 200 infections actually result in severe infection. And what does it look like? Well, you get the bite. Even up to 2 weeks later, you might not have symptomatology, but you'll start to have fever, headache, vomiting. Then it'll progress to more severe symptoms, which basically, demonstrates that this infection is progressing to the central nervous system. So you might have frank encephalitis, mental status changes, seizures, and it could progress to death. There's that 20 to 30% case fatality ratio. And even among people who have that severe CNS infection, if they do recover, there are a number of people that have lifelong residual cognitive, neurologic, or psychiatric effects. So the risk is rather low, even among the endemic population, so 1.8 cases per 100,000. But it is something to think about, especially for your travelers that are going to be perhaps expatriates moving to those countries and those areas. We have missionary families that come through our clinic. Sometimes we have diplomats as well. But you'll have NGO workers that are perhaps being stationed over there. And I'll also have researchers, so wildlife researchers or others that are going to be living in remote areas, perhaps even camping because of their research in these remote areas and exposed to a lot of mosquito bites. So again, these are reasons for you to encourage vaccination. Now, prevention, again, clothing and insect repellent is important because of the mosquito prevention. There are a number of globally available Japanese encephalitis virus vaccines. Here in the U.S., we have one called Ixiaro, which is made by Valneva. It's a 2-dose vaccination. The 2 doses are traditionally separated by 28 days apart. It's approved for children 2 months of age and up. Now, it's not a long-lasting vaccine, so we think that a year, if a person were to continue to be exposed or potentially at risk for Japanese encephalitis, that you would have to administer a booster dose, 1 booster dose per year for the years that they continue to be exposed or at risk for Japanese encephalitis. Now, the contraindication, again, is to the components of the vaccine itself. And the immunocompromised may be vaccinated. It's just that we expect that the level of protection will be less than an immunocompetent patient. Adverse effects is basically that there is some reactogenicity, but I don't think that it's significantly more reactogenic than a lot of other intramuscular vaccines. The level of protection is pretty good with this vaccine. So after 2 doses, you get efficacies of 90% plus. It's usually associated with a neutralizing antibody titer. So oftentimes we will check titers for patients who continue to be at risk for exposure. So in countries where they might be living in a local medical clinic, they could have a neutralizing antibody checked to see if they need that booster dose earlier rather than later. So sometimes we're able to hold off that booster dose, not at 1 year, but maybe at 18 months or even 2 years by checking those antibody levels, because vaccination is relatively expensive. Now, in October of last year, the FDA actually approved an accelerated schedule so that you can give those 2 doses not 28 days apart, but as close as 7 days apart. But that's only a schedule, an accelerated schedule that's approved for adults 18 to 65 years of age. So for older adults, we still recommend that you give them 28 days apart. And for children or anyone less than 17 years of age, less than 18 years of age should receive them 28 days apart as well. And you can see the booster dose recommendation there as well. So there are, these are pictures from my ongoing research in Bangladesh. And Bangladesh is the ancestral home for cholera, if you didn't know that. So this leads us into cholera. There are two serogroups that are important for cholera infections, serogroups O1 and O139. Cholera results in a rapidly dehydrating diarrheal illness, and it causes many millions of cases in the world. It's because it's much more clinically profound. It's probably better reported, but there is some underreporting. Again, it's associated with sewage contamination of your food and water. It's associated with pandemics and epidemics. So epidemics such as, for example, in Haiti. It was also introduced in Yemen. It's endemic, which means that it's predictably every year during the wet season for many areas of the world as well. There are a number of globally available cholera vaccines. There's only one that's licensed here in the U.S. that's called Vaxchora. It's a live oral vaccine. It's a single-dose oral vaccine that's currently licensed only for adults 18 to 64 years of age. If you look in clinicaltrials.gov, there are some ongoing studies right now among children and older adults. So I think I can say safely that that the company is trying to expand the ages for licensure and use of this vaccine. And the ACIP recommendation recommends that this cholera vaccine be used for adult travelers that are going to areas of active cholera transmission where they might be at risk. These are just data from the licensure study that I performed, but basically I'm trying to show you that that this vaccine is highly efficacious. So 10 days after vaccination, even if you were to ingest cholera, which is what we did here in our human challenge studies, you get 90% protection. And 3 months out, you get 80% protection. There are persons who are at higher risk for cholera that we do try to identify in my clinic. So travelers who are visiting friends and relatives to in areas that have known cholera transmission. So for example, in post-earthquake Haiti, when cholera was introduced, Haitians who lived here in the U.S. were going back to help their relatives and their family members, and they went out to the local village and things like that. And we had a number of, U.S. travelers that returned back from Haiti under those conditions and came back with cholera. So that is a known risk. People who are long-term travelers living in these areas, of course, the longer that you're exposed, the higher the risk that you would get that exposure. Travelers who are adventurous, who basically don't follow or are not able to have access to safe food or water. And people who are perhaps healthcare workers or aid and relief workers, again, working around cholera patients, will be exposed to cholera, perhaps. People who are blood type O actually have more severe cholera. Pregnant women, immune compromised, people who have underlying heart or kidney dysfunction will also have poorer outcomes with cholera, basically because they can't handle the huge volume losses with the volume depleting diarrheas. Now, meningococcal meningitis is another thing that we need to be concerned about when we travel. It's caused by Neisseria meningitidis. There are 6 major serogroups that cause meningitis. We, of course, hear about it here in the U.S. as well, and a lot of the meningitis here in the U.S. is the serogroup B. But in sub-Saharan Africa, which is the meningitis belt, that's really the area where we are hyper attuned to the risk for travelers. And so it's usually during the dry season for sub-Saharan Africa. You're seeing that orange band, which is the meningitis belt. These are the countries in which if travelers are going to these areas between the months of December through June, that's the dry season, and that's when we really see meningitis epidemics every year. And it's usually caused by serogroups A, C, X, and W. There are quadrivalent vaccines that are available here in the U.S. The names are Menactra and Menveo. There's a monovalent Group B vaccine, which is not helpful if you're thinking about protecting your traveler to sub-Saharan Africa, because there is virtually no serogroup B infection in sub-Saharan Africa. And then there's the combination pediatric vaccine, which again does not include serogroup A, and again is not an important part of what we would want to use to protect travelers. So really the meningitis vaccines that we would want to use for U.S. travelers is the quadrivalent conjugate vaccine, Menactra and Menveo. So Saudi Arabia, because of the Hajj and Umrah, has specific requirements as part of their visa application. And so as part of their entry into the country, within 3 years of travel, travelers have to have documented vaccination with a meningitis vaccination. So for children 2 years of age and older, all the way up through adults, so anyone 2 years of age and older, should have at least one documented dose of a quadrivalent conjugate vaccine within 3 years of that travel. For younger children, 3 months of age up to 2 years of age, they should have 2 documented doses of a meningococcal A containing vaccine. And again, what that really means here in the US is the quadrivalent conjugate vaccine. That's why I kind of went through the prior slide that the other conjugate vaccine does not contain serogroup A. Now, when you're going to other areas of sub-Saharan Africa, quadrivalent vaccine is recommended. Okay, so so maybe I should also say that usually I repeat doses every 5 years if they continue to travel to these areas, sub-Saharan Africa, during the meningitis season, that if they had their documented quadrivalent dose 5 years earlier and they're returning back, then it's about time for them to get their next dose of quadrivalent vaccine. So what about measles? That's a hot topic these days, of course. We have, unfortunately, some outbreaks that are going on here in the U.S. Well, for travel, we just recommend that for children that they continue to get their required 2 doses during travel, during their childhood. So what that means is that usually children will get it upon their 12 months of age, and then they'll get that second dose upon going to preschool. So usually that's 4 years of age. If it's a young child that's traveling, upon 6 months of age, they can receive that first dose, and they basically should receive 2 doses separated by 28 days apart. So that's for young children who have not received their doses of measles. So let's say, for example, you have a 13-month-old child. They presumably already received their first dose upon 12 months of age. Then they should receive that second dose upon 13 months of age, and then they can travel. That would be compliant. Now, if you have an infant that's coming in and they're 6 months of age to your clinic, you're administering that first dose of measles vaccine, and you're advising them not to travel until they receive that second dose of vaccination at their 7-month birthday. Otherwise, I would be advising that they not travel, again, because of the risk of measles vaccination. This is a recommendation that I provide. And for adults that perhaps can't find evidence that they ever got vaccinated, you can draw blood and see if they have positive titers. You can also go ahead and administer measles vaccine if you can't find any evidence. Some adults, they can't find their vaccination records. They're really unsure. Maybe they only have 1 documented dose. Again, it's okay to administer additional doses. But what we'd like to avoid is having to give vaccines that really are not necessary. So if they can document those 2 doses at some point in their life, then that's sufficient. All right. So I'll just refer you to ACIP references, and these are really kind of my guidebook for the recommendations that I've provided here today. And I want to wish all of you safe travel. So I think that that's the end of my presentation. I think that gives us about 10 minutes to field some general questions from all of you. So thank you very much for allowing me to share with you today. And I'll now open it up to questions.
Perfect. Thanks so much, Dr. Chen. Before we say goodbye, we would like to offer a little more time for last-minute questions. So please type those questions in the chat box now. And while we're waiting for those questions to be typed in, just a couple of reminders. If you have requested nursing or pharmacy continuing education credits for today's webinar, please make sure you complete the survey, which will pop up on your screen when the webinar has concluded, or in your post-webinar email. The email will be sent out by the end of today, and all CEUs will be emailed out within the next week. And then again, if you'd like to view or share this webinar, the recording will be available on our website along with information for future webinars. Please visit immunizenevada.org/webinars for those details. And it looks like Michelle had posed a question that I just answered as well. As far as the presentation slides being available post-webinar, we will post that on the immunizenevada.org website. There was a lot of information to take in just based on the different recommendations and various vaccines. So with Dr. Chen's permission, we're happy to post those on our website along with the recorded version of this presentation today. And it doesn't look like there's any questions right now. Should you have any questions that you can think of afterwards, please feel free to send those directly to Immunize Nevada's info email. And we just had one question come in. And you can also post those in the webinar, the post-webinar survey, and we will do our best to answer those or field those questions to Dr. Chen as well. And it looks like there's one question that came in is, what is the recommendation for the use of Twinrix in travelers? Is it better to separate the Hep A and Hep B?
Well, so hepatitis B is not commonly something that's encountered during travel because it's a bloodborne infection. So most commonly I'm giving hepatitis A vaccinations, and I usually assess that hepatitis B risk is less. However, hepatitis B is, the risk exists if it's an adventurous traveler and maybe they break a bone or have some other reason where they're going to have a transfusion. So it could be for the very adventurous backpackers or bikers or people who are engaging in these other sport activities in these other countries, where they may not be checking their blood supply. So those would be reasons where you might want to actively vaccinate them against hepatitis B. It could be people who seek, getting tattoos or acupuncture at other countries while they travel. Again, the risk is because if those needles are not sterilized properly, then that could be a risk for transmission of hepatitis B. If it's a healthcare worker and they haven't been vaccinated against hepatitis B, of course, you would have to vaccinate. If there is some hepatitis B risk, or if they desire, for whatever reason, to get hepatitis B immunization in addition to hepatitis A, then I would proceed with the Twinrix. So Twinrix really does have a good role. It's just that, again, if you're seeking to have rapid immunization prior to travel, I might stick with the hepatitis A vaccination. And typically this doesn't, this kind of conflict doesn't occur in my clinic because hepatitis B is less of a risk. However, there are people that, again, I want to fully vaccinate against both, and so I will proceed with Twinrix. I hope that answers the question, but there are kind of nuances to the purpose for why you might or might not want to combine hepatitis A and B vaccination.
Perfect. And Tanis, if that did not answer your question, or if you had any follow-up questions, just let us know. We're happy to pose those to Dr. Chen after the webinar today as well. Well, Dr. Chen, we'd like to thank you again for presenting for us today. There was a lot of really great information, especially ahead of the travel season that we're encountering for summertime. And thank you also to those of you who participated today. Have a great day.
Thanks so much, everyone.